So I just want to talk a little bit about ACRs here. And, it's interesting, ACR terminology, didn't do many of them before fellowship. Both anterior column realignment, reconstruction, not totally sure what the appropriate terminology is. I've seen it said both ways. The importance of the anterior column, obviously, in the way I was taught, obviously it's a very important structure. It gives us our foundation to keep the architecture of the spine. Some of the spinal pathologies that we've used it on, this will be a little bit more extensive, talk about some of the more advanced things that we've done, and then also some of the more straightforward approaches to using anterior column reconstruction approaches. And then just talk about a few of the older things that were used, ways to reconstruct the anterior column, and then how we, using a lateral approach now, have a little bit safer ways, less invasive ways of getting the same outcomes. And we'll talk about some of the patients that are good candidates for ACR, as well as some of those you might not want to be as aggressive on. So looking at our anterior column, this is the strut. We've got three columns of the spine. The posterior column is our tension band. So you have to have both of these really intact in order to keep the architecture of the spine. If you do one without the other, that's oftentimes when you find yourself losing the correction that you've gotten, or getting a good correction and having it be short-lived, and then a few months or years later, your patient comes back with significant problems above or below your construct. And then that middle column is where the pathology is. So, anterior and posteriorly, we have the robust structures to kind of support the spine, and then in the middle we have our, where the dura is, where the spinal cord is. That's where our stenosis may be, whether it's foraminal or central, but the problems that bring our patients in the first place. So in my mind, I've always looked at it as kind of we've got our Golden Gate Bridge here, but our tension band in the back, the structure is the actual road in the front. You have to have those in order to have a functional bridge. And then the cars passing through is, for some reason in my mind, this always worked for me, but, the information that's coming down your spine to your nerves, the cars passing through, you have to have the front and the back in order to keep the information flowing. So there's several different cases that we would use our anterior column reconstruction for. This is a traumatic burst fracture here, where you've got the posterior column looks to be intact, but you do have retropulsion of that middle column into the canal, compromising the nerve roots, and something that we can use our ACR techniques on. Tumor and infection, this one was actually a tumor case, but you can see that is also in that middle column, pushing back into the spinal canal. These are kind of more extensive approaches where you might need to take down that entire vertebral body to decompress the canal, and we can do those through ACR approaches. And then degenerative changes, where this patient has a pretty flat back deformity there, and you can use a little bit more of a less aggressive approach, maybe do inner bodies at different levels and try to reconstruct that lordosis of the spine. And just briefly want to touch on, our parameters, our pelvic incidence, lumbar lordosis. You can really come in with a very distinct plan as to how much lordosis you want to dial in. Each one of the constructs will give you a certain amount of lordosis in the cage, but it doesn't always translate to that much in the actual patient. You can say, oh, this is a 30-degree lordotic cage. You're not always going to get that much at each level. So know that you may need to use a little bit more aggressive approach in conjunction, or you may not get all those results. You really want to look at the imaging intraoperatively to see how much you're actually getting. So some of the older approaches here, we talk about reconstructing the anterior column. These are our titanium cages. You're doing a full corpectomy here. Obviously, this was not done through a lateral approach, but you could imagine when we talk about all those, the lumbar plexus, if you do try to do a static cage, you have to get a full dissection top to bottom, if you're looking at it laterally, from the very bottom of the cage to the top, and the size of the incision that you would need to use to get that full cage in there is pretty extensive. It's going to be an open type approach. You really can't use minimally invasive techniques to put this kind of cage in. This is kind of our old standard of what we used to do to reconstruct that anterior column. And, with this, you're, obviously going to either need to do, trying to snake that around nerve roots or having to do extensive anterior dissection to do an anterior approach in order to get this kind of cage in. But do have good results, but you can see even in this example, you've got quite a bit of subsidence there where that cage is pushed down into the body below. Femoral or iliac allograft, these are, again, older techniques, but very effective. You rarely get growth of bone kind of through that cage or here through the graft. This is a femoral ring that's been shaped into a lordotic position, just to give you that reconstruction. And you've got pretty good reconstruction of the lordosis here. And you need something up there to give us that appropriate anatomic shape. We wonder about how rigid this construct is with the minimally invasive posterior and just one level above and below. Sometimes that fixation is not robust enough to last. This is probably going to look good in the short term, but may not be as durable of a construct in longer term. Cement is another one where, again, we've kind of looking at the older techniques that have been very effective. This is obviously, though, if you look at the architecture here, you're not getting any sort of correction with that cement. It's really just a space filler. So everything that you have to get posteriorly. You may be able to get a distractor in there to get some correction, but it's really not going to hold. The cement's just going to fill that space. In cases where you have a palliative treatment where you're just decompressing maybe a tumor or a very sick person with an infection, these can be very effective to get them through that initial insult, but it's not going to restore the architecture like we'd like to do in the ideal situation. So getting into some of our lateral techniques, we have, traditionally we would use these are more of a square type implant. And again, it's a much smaller approach. You can use the lateral approach, whether it's oblique or transpsoas that we've talked about before. And you really need to make sure that your disc preparation is good and you can't really open that space up. You have to take what you get, and you can use a little bit of anterior positioning maybe to get that square cage in, but it's not going to give you the amount of correction that you would hope for. And we talk about anterior column realignment. We also have some of these lordotic cages above or expandable cages here. This is more of a square type. This is a lordotic expandable. So kind of all combinations, the very popular technique now with vendors to try to say, oh, this is the best. We can get into materials a little bit later if we want to have that discussion. But, realistically, if you're looking to get the most correction, you can use when we talked about the release, so very controlled release of the anterior longitudinal ligament, you can get that with the static cage up here, but you don't have any means for fixation. If you do find that that's very unstable when you're putting it in, you can actually, I was asking Rod about using the lateral, you may have the starting point, everything's good, and as you start to hammer it down, it can start to migrate forward. So if it's very loose, if you do a complete anterior longitudinal ligament release, one of these cages without fixation can actually migrate forward, so something that you want to be aware of. This is one of the examples where you can have fixation above and below. I would say in the case where you're putting this in flat and it's becoming more lordotic as you open it. So some people describe using an approach where you come across the anterior longitudinal ligament and just release half of it. And then you can use the strength of the cage to actually expand and slowly open it up. Once you find that you've gotten enough at that level, you can kind of put the screw in and stop there and move to the next level. And again, you have to really plan ahead, because if for some reason you can't get a cage in because of that, you looked at high iliac crest, you're planning on doing 3-4 and 4-5, you're only going to get that much from the single level, and you have to know that your plan might change at that point. Obviously these are all complex things we do in spine surgery, but something you definitely want to be aware of as well. Just talked about these with the pictures as well, but the hyperlordotic cage, can give a very exaggerated curvature. If you crank it out all the way and you're doing 2 different levels, you can get up to 15 degrees, 2 levels, and you've basically got as much correction as a PSO from 2 levels doing an anterior longitudinal ligament release. And so when we talk about who needs an ACR, if you have a patient and they don't have the appropriate architecture, just in my teaching, you want to restore that. If you want a durable surgery that's going to last the patient a long time, you can do a decompression and you can fuse them in a straight position. They may have good results over the short term, but it's very rare that they're going to have a lasting result where they're 10, 20 years down the line, they're not going to continue to have problems if you don't restore that appropriate architecture of the spine. So in my mind, if they don't have an appropriate alignment and you're not addressing it, you're not doing that patient as much of a favor as you could be. And also, one of the other things that I wanted to talk about is, as we look at, Dr. Shaffrey has looked at this pretty extensively. As we get older, we have a natural kyphosis that happens to us. And in a patient that is, in their 50s and they have a PILL mismatch, you want to restore that back down to 0 so that it's matched pretty perfectly. But in patients, if you're too aggressive in an elderly patient, they have basically weak posterior musculature. There's some thought that there's an increased incidence of proximal junctional kyphosis because they may not have the strength to stand upright. So if you give them a PILL of 0 and they don't have the strength to stand upright, then that's almost too much lordosis for them. So you can actually accept a little bit more PILL mismatch in the elderly patient. So if you're planning on doing a degenerative case and you really want to get some lordosis in that older patient, 70 plus, you may want to accept a little bit less in terms of less correction because they're going to be happy without that 0 PIL kind of congruence. And also maybe at lesser risk for PJK. We don't really have the data to show that yet, but something I would definitely consider. And this is just one thing that one of the papers I want to look at came out of ISSG last year, where they looked at, it's just a short series and really not a whole lot of data out there on, this is anterior column realignment, using a minimally invasive lateral approach, doing ALL releases and putting in lordotic cages, and then backing it up with a percutaneous posterior fixation. And they actually got similar correction between ACR and PSOs. Again, this was a historic cohort. And when we talk about restoring alignment, in a PSO is not restoring the anterior column or giving us any sort of reconstruction. We're actually taking away part of the anterior column to try to give us the appropriate alignment. When a patient doesn't have lordosis, you want to give them a means of achieving lordosis, and that PSO has been a very effective tool. Obviously has its drawbacks, and that mainly comes in the form of really severe complications that can happen. And we see that in the significantly less blood loss, but actually they said in this cohort that the they're saying that the infections, there was no difference in between the number of infections or the number of complications. Obviously, infection is something that didn't happen much in this cohort, much more common in posterior approaches. But if you look at what kind of complications did happen. So there are more. This was a non-significant difference between the PSO group and the ACR group. But looking at the motor deficit, we know that's a complication that we try to avoid in our lateral approaches, but it's something that's there. But they didn't. It's kind of surprising to hear that they didn't have more complications in this PSO group. I wonder how accurate this is, because in 3-column osteotomies in some other series, they've shown, complications over 50%. And this is kind of grouping them all together, but just a good study to show that you can get that equivalent reconstruction of the lordosis, and this was all comers, pelvic tilt, pelvic incidence, and lasting over time, over a 2-year follow-up. So I thought it was a pretty good a study to show us how effective it can be, especially when you're comparing it to one of the most powerful osteotomies that we have in our arsenal. So that was, again, cases for a conservative approach. Briefly talked on this earlier, but other things, medical comorbidity, doing an anterior column reconstruction is a lot more risky. We saw that, coming in with the blade across the vena cava in the aorta is, if it's a little bit nerve-wracking, to say the least. And if you're doing this in a patient that's sick, adding that complication on top of their pre-existing medical comorbidity could be something that keeps them in the hospital for a very long time, or gives them mortality at the end result. And we don't want to really consider that in those patients. Again, so. Some of my thoughts on ACR. Obviously, it's a very powerful approach. We'll go over it pretty detailed in the in the lab. In some of actually getting into the details of the cage insertion and how we do that with the expandables and with the hyperlordotic cages as well. Just wanted to see if you guys had any questions about it. Please.
In terms of ACR and the added complexity.
Mm-hmm.
Is there, when you code for the case, is there additional coding to reflect the additional complexity and risk that you entertain?
Coding is, there are ways to, you can try to say that you're doing, there are ways to code where you can try and say that you're coding for a 3-column osteotomy. I don't know, how well that comes across with your, actual reimbursement versus the coding. But I don't know that there is, in terms of lateral approaches, because it's, you are doing a little bit more work. It is a riskier procedure, but I don't think that the coding, and from what I know, does not reflect that. You're doing it to get a better outcome in terms of alignment, but it's not something that you get paid more for as a surgeon.
That is a great question, because the lateral procedures do not have a true 3-column osteotomy code. It's a very perceptive question. So your only real option there is to basically identify extra complexity and quantify that in a time effort exactly using a modifier. Very insightful question, because both anterior and posterior do have that feature. Lateral so far does not, and your coder will not allow that as an associated code.
The one thing it does make it does make your blood pressure go up during the case. So I think I don't think you can code for that, though.
I think I'm going to give a naysayer talk later, but the question I have for you is, are there certain levels where you just would not want to do it, aside from the patient physiology, i.e. L4 or 5? Is that just a contraindication? Maybe extrapolate also in some clinical conditions where you're far more apprehensive, i.e. discitis, osteomyelitis or so.
I don't think 4-5 is a contraindication to doing lateral. I think that Dr. Uribe has talked about ways for avoiding the complications. If you're not very exacting, and obviously, if you can't get there, you can definitely give yourself problems. Really high iliac crest is one. That's just physically you can. They have angled instruments to try to get in that space, but it can be very, very challenging. But I think that you can, with appropriate techniques, keep it to an acceptable low. If we talk about posterior approaches, we have a number of complications with those as well. But you want it to be at an acceptable level. And in certain people's hands, 4-5 may be a contraindication if you find that you're not able to get that retractor in the right way. But I don't think that it is, and I think that you can do it safely.
I've actually on a 4-5 had to remove a little bit of the crest, and that helps too.
Yeah.
It's bone there.
Are you, for the ACR, are you typically just taking what it gives you in a lateral position and like doing perk from behind, or are you pairing the ACR with facet osteotomies, a Ponte osteotomy from behind and closing it down to maximize your
I prefer to do, come in laterally and then back it up with open posteriorly, because I think it gives me more options. If you do lateral and you get the correction that you need, then you can basically just lock it in with a posterior perk fixation. But if you don't have as much correction as you wanted, or you want to do a really extensive decompression, I think it gives me more options. I prefer just to come back and really look at it well, and then I can do more active compression. You can get a little compression through a percutaneous approach, but if you really want to crank that down a little bit more, you're not going to have that option if you do percutaneous.
All things are equal. Anterior first, posterior second, or vice versa, posterior first, anterior first. What are your thoughts in terms of if you want to restore lordosis, doing it anteriorly first versus posteriorly first, and then filling in the gap from a secondary minimally invasive anterior procedure?
I think that I like to get the correction anteriorly first, just because taking down the disc gives you a lot more mobility posteriorly, and you can do less work. If there's a level that you can't get to from the anterior approach, if you do posterior, you come back and you've got your plexus in the way and you can't get it, then you have to come back again posterior if you want to get that correction. So I think that there's a little bit more fiddle factor to the lateral approach, and so you don't always know if you're going to be able to do all the levels you had planned. So that gives me more options to come back posteriorly afterwards and back it up.